Jennifer, can you hear me?
I can.
I can only see you. Hang on. I don't know if Paula can hear. Let me just chat with her. Oh, yep, there, we started it. Okay. So welcome, everybody. I am John Santapietro, for those who have not met, and I'm Physician-in-Chief of the Behavioral Health Network, and very excited at this to be here to get to listen to and dialogue with Dr. Ferrand on the topic that she's going to be talking with us about. Delighted to introduce her. She has put the code up and the instructions for getting CME or CE on the screen for now, and we'll probably be able to let folks know what that is in the chat along the way. In terms of the frame, we're going to go until 1:15 presentation, maybe until about 1, and then hopefully an opportunity to ask some questions and have some dialogue. I'm happy to help facilitate that. You can, send me a chat, or you can put something in the chat, or we can also unmute you when it comes time for that. So I'm just going to briefly introduce Dr. Ferrand, who is going to be talking with us about, is it over yet? Now that is ambitious. This is not a run-of-the-mill discussion, and but let me just say a little bit about Dr. Ferrand for those who have not met her. Dr. Ferrand is a board-certified clinical health psychologist with 17 years of experience at Hartford Healthcare. She currently works as the director of Hartford Healthcare's Wellbeing Department, which focuses on improving the well-being of all healthcare workers. She guides the development and deployment of strategic initiatives and leads the team's research and educational activities. She remains involved in the Behavioral Health Network and their activities, including those focused on violence and suicide prevention, something that's been a significant interest of hers, and helps to disseminate that work through Hartford Healthcare. She also works, importantly, clinically in private practice with a current focus on helping healthcare professionals heal from trauma. She did her undergrad at SUNY Geneseo. Then she did her graduate work at the University of Hartford, her clinical internship and postdoctoral fellowship here at the IOL. And just a couple of things that I thought I might, point out. One is I really had the pleasure of appreciating her capacity and talent as a leader here at the Behavioral Health Network when she was here, and then now to see her have an impact in a larger way across the system is extraordinary. Really thankful, in fact, that she is in her role at the Wellbeing Department with her team, Sharon Kiley, Hillary Landry. They are doing a fantastic job, and having somebody there with a deep interest from a psychiatric, psychological perspective, I think differentiates that department. So, and in terms of the topic, again, it is ambitious, it is leaning in, but there's nothing, more important. Is it over yet? Healing the healthcare workforce through a trauma-informed lens. And with that, Dr. Ferrand, the floor is yours.
Thank you so much, John. I always feel a little nervous presenting to this group because you ask such challenging questions, but hopefully I'll leave enough time for us to get to them. And hopefully you're seeing that I have nothing to disclose. And today we're going to be talking about whether it's over yet. I'm going to start with this image that I really like because we refer to this a lot in well-being, that doing this work is like building a plane as you're flying it. And it's a pandemic, so the plane is also changing course the whole time, which really is to say that we're part of an emerging science here. And while that's intimidating, it also levels the playing field because there are no experts in this space. So I'm really here as an observer to the organizational process these past 2 years and as an actor in the creation of a path forward. And you're here because you're co-creators in this roadmap. And I thought I would frame the work in the trauma-informed model because this is the work you all are doing already. And I want to help translate your work to the broader organization, sharing the wisdom of the groundwork you're laying, and helping us all to ultimately treat each other with the same humanity that we bring to our patients. So our learning objectives today are to talk about the healthcare worker experience and how we can address it from a trauma-informed lens. I think there are things that the organization has to do, there are things that leaders have to do, and there are things that we all have to do. And so what I'm sharing today is, again, an emerging science, and I've really been struck by how much information is coming to me from my seat as someone who cares about healthcare worker well-being. So part of my effort today is kind of an attempt to distill some of that and present it chronologically so we can step back a little bit from the experience and start to think about how we can carve a path forward. So it also feels like this past 2 years has been a lot of scrambling to understand what's happening and measuring the amount of despair we're all in. And so this conversation is more about switching to a healing mindset and thinking about the ways we can do that. And I'm hoping to make the argument that this healing mindset ought to take the shape and form of a trauma-informed model. So I was thinking about how sometimes when you're sick, you don't realize how bad you feel until you start to feel a little bit better. And that made me wonder how much of us have actually started to feel better. It might be, I don't know if I've actually started to feel better, and it might be because it feels unclear whether this is actually over. And so I posed the question in the title today because I'd like us to think about this transition from an acute crisis mode to long-term recovery. But I'm not sure how we know that we've gotten to a point where this work can start to occur. And so the disaster response model from SAMHSA that you see here describes stages of emotional response to disasters. And although it was developed for discrete events rather than for ongoing crisis, it's a conceptually useful way to think of the process because progression through these stages does not always occur in a linear manner. And in organizations, we might be in several stages simultaneously. And although the last stage of this model suggests a return to baseline conditions, another perspective actually emphasizes the potential for post-traumatic growth, which we could define as positive psychological change after you've struggled with challenging circumstances, crises, or trauma. And this is a different way to visualize the various trajectories of this long trauma and where we are currently. And from my vantage point, it seems like we're dealing more with these fourth wave phenomena, both among our patients and also ourselves. And this is where I think behavioral health professionals can really be helpful, not just in teaching our patients, but also in teaching our peers and our leaders about things like sitting with discomfort and acknowledging how painful and difficult reality is in this moment without necessarily trying to fix it, but still moving forward. Okay, so I said that we were first going to talk about the impact that COVID has had on the healthcare workforce. And certainly I could spend an hour talking about this, and I'm sure this will come as no surprise to anybody. But here's a word cloud from June of 2020 when we asked some Hartford healthcare colleagues, it's under 100 people, to name some of their feelings during the COVID crisis. And the overwhelming emotional state at the time here internally was one of anxiety and fear and frustration. But this shows that we can also hold competing feeling states at the same time, and that in the midst of suffering, moments of joy and gratitude can occur. And we know that from really extreme, terrible situations that post-traumatic growth can actually occur, which reminds me of a quote from Anne Frank, who said, "I don't think of all the misery, but of the beauty that still remains." And that is some powerful reframing. And, I think if we did this word cloud exercise now, certainly different feeling states would rise to the top, probably exhaustion being one of them. But I'll invite you to also consider an exercise that Brene Brown does, where she asks people to name 2 feeling states that they're having about a situation. So think about, and this often sort of elicits that idea that you can hold competing states at the same time. So thinking for yourself, how are you feeling today about where we've been and where we're going, and some of the impacts that the pandemic has had on not only your work life, but also your personal life? So I'm talking primarily about trauma today and thinking about trauma, which is certainly difficult to quantify. But we know that over 3,600 healthcare workers died the first year of COVID, and 2/3 of deceased healthcare workers for whom data exists identified people of color, identified themselves as people of color, which reveals deep inequities tied to race, ethnicity, and economic status in America's healthcare workforce. Also, it's true that lower paid workers and those who handled everyday patient care, including nurses, support staff, and nursing home employees, were far more likely to die in the pandemic than physicians were. More than half of those who died that first year were younger than 60, and in the general population, the median age of death from COVID was 78. So among healthcare workers in the database, it was only 59. We also know that pre-pandemic studies showed rates of PTSD in frontline healthcare workers from 10% to 50%. We know that the suicide rate for physicians is higher than in the general public, and for women physicians, it's twice the rate of suicide for women in the general population. And review of studies from January to May of 2020 highlight the presence of trauma-related stress, with a prevalence ranging from 7.4 to 35%, particularly, again, among women, nurses, frontline workers, and in workers who experienced physical symptoms. And this is consistent with data collected in a published study by Hartford healthcare authors. The image here is courtesy of Dr. Coles and shows the PTSD symptoms reported by a national sample in the green bar and a Hartford healthcare sample in the purple bar. And in a more recent survey, 30% of healthcare workers are considering leaving their profession. 60% report impact to their mental health during the pandemic. And I read an interesting study from pre-vaccine times about moral injury. And so in this qualitative review of study of 1,350 healthcare professionals in 2020, respondents reported significant changes in their personal and professional lives during the course of the pandemic. So common themes were feeling isolated from non-healthcare professionals, feeling alienated from their patients, betrayed by coworkers, administrators, and the public. And the authors put healthcare worker emotions in a chronological progression, starting with fear in phase 1, moving to fatigue in phase 2, isolation and alienation in phase 3, and then betrayal in phase 4. And so I wonder about the degree to which the moral injuries or even the long-term stresses of working in a morally injurious environment are at the root of some of the trauma that we've all experienced. And I think the occupational impacts of moral injury and vicarious trauma are things like burnout and compassion fatigue, and then the personal impacts are anxiety, depression, and PTSD. Last point I'll make is that, for many healthcare workers, our response to distress often is to work harder. And I think that we saw that in Hartford Healthcare, and I think that aligns with what we saw from a data standpoint these past 2 years when we're thinking about engagement, the engagement survey, and what we saw in terms of decompression, which would be sort of your ability to leave work at work and relax when you go home. It really has declined during the pandemic and has not yet returned to pre-pandemic levels. So let's assume that everyone has endured some sort of stress injury these past 2 years. And for healthcare workers, it's worth pointing out that stress can come from one of 4 major sources. And obviously, how one reacts to stress may vary. You can have a minor reaction to a serious stress injury. And if left untreated, it's these serious stress injuries that can evolve into persistent occupational or personal problems. And this is SAMHSA's definition of trauma, and it comes from an expert panel who combed through many definitions to arrive at this one, which is designed to be relevant for public health agencies and service systems. And I like it because it's not a psychiatric diagnosis and it normalizes the experience of trauma. So when we're thinking about universal language and how we want to talk about trauma as a larger organization, I think it's important that we agree on some common terms. And as we know, as here in the Behavioral Health Network, trauma is an almost universal experience for the people we treat. And the need to address trauma is increasingly seen as an important component of effective behavioral health delivery service. And so, in my opinion, it's also the key way for us to understand the experiences of the healthcare workforce, and it provides us with I think a real concrete path to solutions. So again, I'm going to stick with SAMHSA's definitions and language throughout this conversation. And for healthcare workers, whether you're a clinician, an administrator, or in a support role, we've all experienced different but similar events personally and professionally. And they've affected us differently in the acute phases of the pandemic. In the acute phases of the pandemic, organizations have attempted to impact the experience of the COVID of the pandemic for the workforce to help prevent trauma. But it's worth noting that we didn't really have a template for what we ought to do as an organization, because the only one we had for pandemics in modern times was the SARS virus in 2003, which was much different than what we've endured in COVID. So everything I just shared is background that sets the stage for the next part of our conversation, which is about the key assumptions of a trauma-informed model and how we might use it to support the healthcare workforce during and after a crisis. And this schematic spells out this process pretty clearly. So a crisis happens, people get a stress injury, and in order to avoid having your workforce develop a chronic stress injury, you should provide support. And in the beginning, in the acute phase of a crisis, that should come in the form of providing for basic needs, meeting people's mental health needs, and communicating through transparent leadership. So a question that naturally emerges is, whose job is this? And I think it's a really complicated question because in a crisis, especially in an unpredictable crisis like this one was, the organization is trying to figure out how to keep everybody physically safe and the patients cared for and the staff employed. And even in organizations where there are dedicated resources and people to do this work, it can feel very siloed, with people being really careful to stay in their own lane, but also people not knowing what's in their lane and what's not in their lane. So really the better way, I think, to visualize this is not necessarily everybody staying in their lane and competing for the same goal, but more of a like a collaborative image, like traffic merging, because everybody's going to the same place, and hopefully there can be some collaboration and kindness on the road to help everybody get to their destination, wherever that is. And to the point of whose job is it to do what, Hartford Healthcare is one of few organizations of its size to have a dedicated chief wellness officer and a department, though small. So our chief wellness officer, Dr. Sharon Kiley, contributed to a publication last year that defined the role of the chief wellness officer during the pandemic. And what they did was describe 4 phases represented here that they saw in their organization, the things they saw emerge in the organization, and then what they did about it. So for instance, in the pre-surge phase, which they described sort of as the planning for the onset of community infections and hospitalizations, people were sort of consulting the limited literature and trying to develop best practices for what to do to help the workforce. And in this phase, most of the work, what we saw in organizations across the country, was about promoting things that already existed, like the military's stress response continuum model, and relying on what we know from disaster psychology. So for example, this is the stress response continuum. A lot of organizations used this as a quick way for people to identify and communicate their mental state. And some organizations had this on badge tags and on pocket cards, and a lot of work in the earlier phases was around making sure there were resources for people, communicating about these resources, and then really just making it as easy as possible for people to access them. And here's the stress response continuum translated into next steps in Hartford Healthcare language and Hartford Healthcare resources. As another example of work in the early phases, this was a publication that most organizations relied on to frame their response to healthcare worker needs. So early in the pandemic, the overwhelming experience was uncertainty and anxiety, and the needs people described in things like listening sessions and focus groups were to feel heard and protected and prepared and supported and cared for by the organization. And I think this really, looking back, really provided a clear, concrete approach for how we might address these basic needs, sort of like on the bottom of Maslow's hierarchy of needs, really just to make sure people had those basic things met. And the principles of psychological first aid were also really relevant and relied on early in the pandemic. This comes largely from disaster psychology, but it's also a trauma-informed model in that the key actions are to enhance safety and to provide practical assistance and to connect people to social supports. And so one of the things I think we'll see as a recurring theme when we talk about the application of a trauma-informed model is that these core tenets of safety and meeting practical needs in a collaborative way, and then fostering connections with social supports sort of rise to the top as things we should really be concerned about and focusing on in our longer term recovery efforts. So back to the schematic. Where we're going is to move from acute disaster management to longer term management, what is here referred to as recovery aid. And this is where I think a trauma-informed model is particularly helpful, because what we're talking about is organizational and culture change as opposed to simply the concrete interventions that the organization does to help people. And, so I guess like the only thing we have left to do at this point is to figure out how we can do that, especially when our ability to heal is impacted by continued threats to our well-being in the form of staffing shortages and the many other stresses that you're experiencing currently. The sanctuary model is a trauma-informed blueprint for organizational culture change. And I like this quote from Dr. Bloom because a lot of what we do in well-being and related to culture change more broadly is like planting little seeds because it takes time and nurturance for them to grow. And back to the story about whose job is it to do what, we've actually learned a lot about the role and responsibilities of a wellness leader during and after a crisis. So broadly, what you see here is that the wellness leader sows the seeds of culture change by optimizing the organization's response to crisis. They help make sure that operational decisions are being made with the experiences of the workforce in mind. The wellness leader helps leaders to lead humanistically. They identify resources and they demonstrate innovation and creativity to meet people's changing needs, often with no funding. So that the work is really in relationship building and directing the traffic from those multiple lanes so that they merge into one lane harmoniously. So let's spend a little bit of time getting into the meat of a trauma-informed model and how this can help frame our next steps. And I know I'm telling you things you already know in behavioral health, but it's worth reinforcing that trauma-informed care refers to a philosophical or cultural position that integrates understanding and awareness of trauma into practice. And again, I'm sticking with SAMHSA's model and language here, and their concept of a trauma-informed approach is grounded in a set of 4 assumptions and 6 key principles. And the assumptions here show that a trauma-informed organization realizes the widespread impact of trauma and understands potential paths for recovery. It's a strengths-based model that recognizes the signs and symptoms of trauma in clients, families, staff, and any others involved with the system. And it responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization in staff and patients. I'm sharing this to highlight that a trauma-informed model is not psychotherapy, although there are organizational and clinical or individual interventions. And the keys are empowerment, right? Using individual strengths to empower them in the development of either, their own treatment or organizational decisions that affect them. It's giving people choices. It's maximizing collaboration. It's prioritizing safety, and it's being trustworthy in terms of transparent and frequent communication. So back to the 4 R's applied to the healthcare workforce. What do we actually need to do here? Right? So one thing we have to do is, in our own organization, build awareness of trauma, validate and normalize help-seeking behaviors, develop policies and educate our staff, and develop the capacities of our leaders. In the recognize bucket, we have to help people recognize those in distress. We have to help people recognize when they themselves are in distress and what triggers are for that distress. And we have to help colleagues. I think included in this is helping all colleagues feel included and valued and to foster belonging. I know there's been a lot during the pandemic. I've observed a lot of, I think, stratification of experiences so that, the nurses feel this way, the physicians feel this way, the respiratory therapists feel a different way, the behavioral health workforce feels differently, right? And there's not been as much of a conversation about the universal experience that we've all had together. I think in this domain, in the response bucket, we have to obtain the voice of all our colleagues, and we have to co-create interventions. We also have to recruit and continue to develop inclusive and wellness-centered leaders. And I'll talk a little bit more about what wellness-centered leaders might do in a little bit. And then in terms of resisting trauma, we would sort of work to promote a strengths-based model where we're helping people to actively cope and thrive as opposed to either surviving or dropping out, thinking about second victim phenomenology. And then we would help the organization to plan ahead and be prepared, right? So I think we've learned a lot organizationally around our disaster response protocols and how to be a little more prepared next time a pandemic happens or something like this happens. So I like this visual from the CDC about the 6 key principles of a trauma-informed model, because these highlight that these are guiding pillars rather than a prescribed set of practices or procedures. And in the wellness space, for example, while peer support might be a concrete initiative or a thing that we do, and it is, it's also a way we do things. And that sort of promotes culture change, right? So that wellness is not just a thing we do, but it is also a way we do things. Or we're moving from a mindset where we think of wellness as a thing we do to more of sort of the way we do things, in the sense that it's built into the very fibers of how we function together. So while we're co-creating a trauma-informed model, we rely on the voices of peers. We promote safety and trustworthiness in all we do. We collaborate. We empower all stakeholders. And we prioritize inclusive thinking that takes cultural, historical, and gender issues into account. So I'll spend a little time talking to you about, that more on that sort of individual level. What does a trauma-informed model look like in practice if you're thinking about what kinds of supports your workforce needs, and how you're going to provide those to your organization? And I think, under the domain of rest, it's really important to think about physical interventions to address nervous system activation and to calm the stress response. So some of the things we might see in this bucket are things like respite rooms, which we saw early in the pandemic in a lot of our local areas. These have sort of fallen off, partly because of space issues and also because healthcare workers generally don't have the time to pursue these kinds of things during the workday. So that means we also have to help people to take advantage of time outside of work to be doing active recuperation and rest to really sort of mitigate that long-term physiological stress response. And in the domain of peer support, we think it's actually really integral to a workplace well-being program. And I'll tell you that in Hartford Healthcare, we've been trying to do this both in formal and informal ways. We currently have a provider peer support program that serves physicians and APPs, and we have a nursing peer support program. And we're in the process of recruiting and training more peer supporters across the system to be available to all. We don't have people, true peers for all our roles, so that if you're a respiratory therapist, we'll certainly provide peer support for you, but we'd like to have some respiratory therapists that are trained and at the ready and able to be deployed to provide a one-to-one supportive interaction with a peer in need. And also here, I wanted to highlight again that the reason peer support is important is because it really relies on people's lived experience and promotes the fact that we're having a shared experience and that your struggle is my struggle and that we can come together and be vulnerable in that. So this next bucket is therapy, and this maybe is the wrong word, but I think this can take many forms. I certainly am a proponent of psychotherapy. I think everybody should have psychotherapy, but we've seen this done creatively in a lot of other places. And I want to just mention that I read an interesting article about an online intervention to improve mental health symptoms. I think this was done in Canada, and they wanted to improve emotional symptoms associated with COVID by giving people self-paced online education modules. They did 8 modules. They were 30 to 40 minutes each to be done in theory over 4 to 8 weeks. And they decided to focus on 3 potential mechanisms. One was social isolation and withdrawal from physical activities or positive activities. Second was avoidance of thoughts, feelings, and situations related to stressful experiences. They also looked at negative cognitions about the cause, meaning, or implications of traumatic or extremely stressful events. And they got some good feedback. They thought that this online education program, while not telehealth, while not individual psychotherapy, was accessible to those who maybe were a little resistant to the idea of individual psychotherapy. And also, in the domain of therapy, most organizations do have an EAP program. I'll tell you that here in Hartford Healthcare, ours has been pretty underutilized over these past couple of years. I think more underutilized or less utilized than in non-pandemic times. And this was also seen in other organizations as well. In reflection, I think the important thing to note here is that there's an opportunity to teach the organization and sort of highlight and prioritize the importance of mindfulness, really because it's a leadership behavior. It's our first leadership behavior, and because it's integral to be in terms of giving people the skill that's required to identify distress, possibly also the skill related to seeing it as a temporary experience, and possibly also the skill to be able to treat oneself with kindness and approach perhaps an intervention non-judgmentally. I think under the compassion bucket, there's a lot of opportunity for education and support in how to be compassionate not only to patients but also to oneself. I have myself had training in mindful self-compassion this past year, and I think it has great applicability to the healthcare organization in terms of helping us to see that we are having a universal experience together, treating each other with kindness, the same kindness that you would show to a friend or someone you cared about, and then practicing general mindfulness, again, which requires an awareness of both internal and external events, but also a sense of non-judgment. So another priority that would really be important if we're moving forward in a trauma-informed path is collaboration. And we'd see this in a lot of ways, but most importantly, I think it can be seen in healthcare workers being involved in decision making, so that we're not making decisions, so that the executives aren't making all the decisions and then cascading it down through the organization, but there is some bottom-up decision making too, and we're really recruiting the voice of all the people to make operational decisions. And even decisions around what resources people need and how to creatively provide those resources. Connectedness is a primary theme as well. And I think ways we would see this is in commensality, which refers to the benefits that people get from sharing meals together. And it's interesting to look at how this has changed over the past couple of years, now that we don't have so many opportunities to share meals together. And I think most people would agree, most healthcare workers would agree that they're really missing something without having those the sort of the casual conversations that happen during those kinds of interactions, and the really just the friendliness and the sharing that happens when you do something like have a meal together. Of course, there are lots of ways to build community in an organization. I think one way to do it is also to, again, rely on sharing a common humanity, sharing vulnerability, and letting that happen with the aim of building trust in one another and in the organization. This is something a lot of people have consulted us about particularly in the past 6 months or so. How do we, in this new world, how do we do fun things for our teams, and how do we build cohesion and trust in our teams when there are so few ways to do it? The last thing I have here that I think is really integral is control. And what I mean by this is rebuilding people's sense of control over their work life. I think this is really important in trauma work. And if we apply it to the healthcare workforce, I think it relates to giving people autonomy and control over how they spend their time professionally. So I also know that meaning in work is a really important driver for professional fulfillment. And in fact, I cite this study a lot because there was this Mayo study, probably done 10 years ago, that shows that if you give people 15% of their time to spend doing the thing they find most meaningful in their work, then they'll be more than happy to spend the other 85% of the time doing what you'd like them to do that might not be as meaningful. I think it's kind of maybe right now it's a big lift for people to have 15% of their time free to pursue something meaningful. However, it's a worthy goal to aspire to, and it's also something that can be brought into coaching, right? So when we're developing our leaders, we have to develop leaders that can coach the workforce to be able to identify things that are meaningful for them, and then be creative in finding ways to give those kinds of things to people, and cultivating, coaching relationships where we're talking about what's meaningful and what's values based. Is really important. So I encountered this I thought was helpful when I was thinking about sort of concrete ways to help the workforce recover. And I think you'll see this 3-step process from the advisory board is straightforward, it makes sense, and it suggests some questions and priorities that are consistent with a trauma-informed model and can help frame our thinking. So this particular three-step model suggests that the first thing you would do if you're helping your workforce move from an acute crisis mode to a longer-term recovery mode is to actually audit what your system already has in terms of existing emotional and physical supports. And they suggest some questions that you might ask, right? Things like, how many staff utilize this resource? And if there are few that utilize it, then why is that? And is this resource available across the entire system? And if not, should it be? Right? So like that to me speaks to the importance of bringing, being equitable in the way that resources are identified or allocated to people or made available to people. And so then the next part of the plan is to actually craft what you're going to do, right? How are you going to create a recovery plan that's focused on the key healthcare worker experiences that people have had this past couple of years, including fear, exhaustion, isolation, distress, and trauma? And importantly, these questions that are posed help us to think critically about things like, does the organization create space for conversations that let staff express how they're feeling? I can't tell you how it's, well, I'm sure maybe you'll agree. I don't know, maybe not. But what my experience being in meetings is that we've been very, first of all, there doesn't seem to be a lot of transition time anymore. And now that things happen on Zoom, people don't get up and like move around. And we also seem to be much more, at least this has happened for me and my team, we're much more diligent about getting through the process of the meeting, and I think less comfortable making space for conversations around how we're feeling. And I think that's an opportunity for us. But it gets to, how do executives at your organization model vulnerability to their teams? How does the organization ensure that staff receive critical information, updates, and things like that? That's, as everybody knows, challenging in a large organization, especially now, because I don't know if this is true for you, but it seems to be true for me that the volume of emails I get is just astronomical, and I feel like I'm missing things most of the time. So just the amount of information that comes is more, and it seems to come at a faster pace when there's less sort of opportunities in between things to actually process and assimilate that information. And then lastly, I think this last question is relevant too. How does my organization surface and address questions and rumors that circulate among staff? This requires there to be, again, top-down, but also bottom-up communication. So how do you, and this is something I've been challenged with this past year in this role, is how do I have sort of like a line of sight to what's happening throughout a 33,000 person organization, and who's feeling what, and who are my go-to people in all of the places that can share this information with me transparently, and do people trust me? And then the last thing here is making resources easily accessible to boost utilization and scale. I mentioned before that we've seen across the board, and this is true in other organizations as well, that we've really, really scrambled and worked hard to put resources together and make them available to people, and they have been underutilized. So what can we make of that? And how do we move forward, creating a culture where people are more able to access resources, they're available to them? We perhaps need to do a better job of pushing out instead of letting people come to us, which is why the first recommendation here is to make some resources opt out instead of opt in. Typically in organizations, in terms of benefits or wellness initiatives, things like that, you have to opt into them. You have to take advantage of them if you are so inclined, or if you're aware of them, as the case may be. So the thinking is that if we switch that and make things sort of more mandatory, is the wrong word, but it's there for you. And if you don't want it, then you have to do something about it, as opposed to if you do want it, then you have to do something about it. Okay. I'm almost to the end, but I want to talk just a little bit about wellness-centered leadership, because it can really empower individual and team performance, in theory, to address the current problems faced by healthcare organizations, as well as the innovation that's needed to address challenges that might continue to arise in the next decades. So we're all leaders here in one way or another. And I think we'd all agree that the job of a leader is really challenging. There are a number of models to think about the job of a leader. And I think wellness-centered leadership makes a few key points that align with the fundamental tenets of a trauma-informed model. So the foundation of this way of thinking about leadership is care and respect for all people, always. It also speaks to the importance of relationship building, both one-to-one relationships and team cohesion. And last but not least, it's about inspiring change. I certainly know from my seat that there are limited things I can do as an individual in such a large organization. So leading through influence and touching people so that they have the ability and the desire to carry the work forward is really important. I think we can do this through collaborative relationships in which we're redesigning the system together. And we can also do it through modeling vulnerability, which is about acceptance, right? It's about telling people that it's okay not to be okay, and helping people see themselves as having some degree of autonomy and control, meaning you're not a victim of the system and you can be part of the solution. And it doesn't necessarily have to mean that you have a lot more work to do. So lastly, I thought this was helpful in that, again, the SAMHSA trauma-informed model has implementation domains. There's 10 of them. So I thought about them in a timeline perspective, and I added a few that I think are really important. They all support a culture of wellness. So it sort of puts it in this chronological order of like things you should do next, right? And we would start with awareness raising. We would build a coalition. This is like gathering the people and finding the leaders and educating them and making sure they have the common language and are capable of moving this forward and that it's values consistent. Writing policies would happen next. Making sure your physical environments are safe. Training your workforce. Certainly a challenge now, particularly when we're trying to figure out how to train the workforce across our system in a more efficient way. Then we would work on screening, assessment, and treatment services. We would do this collaboratively. We would engage people. We would monitor progress and assure quality. We would probably at some point need some financing, and we would need a sustainability plan. And through the whole thing, we should be doing evaluation in an effort to continuously improve. I don't know if you're hearing that, but there seems to be some kind of alarm going off. Sorry about that.
That's okay.
All right, this is my last slide. And I'll end here to show you how well-being isn't necessarily a thing we do, but it's the way we do things. And we see it in a lot of ways within the Hartford Healthcare strategic framework that already exists. So here it is as one of our values. And we see it in our principles as part of our mission to improve the health and healing of the people and communities we serve. We see it in our goals, which includes enhancing everyone's experience. I see this as the quadruple aim, which considers the healthcare worker's experience as much as it does the patient experience. And lastly, we see it in our priority to build a culture of health and racial equity, diversity, inclusion, and belonging. So I'll end by noting that, I think we already have the tools and a path forward, and that all of the work really aligns with what's already happening. So for example, in the Behavioral Health Network, you have a trauma-informed care AIP, which fundamentally prioritizes the health and well-being of the workforce. You have, incredible work happening in diversity, equity, and inclusion. You have great work happening in violence prevention. And all of these efforts are employee centered to some way because they take into account the experience of the people doing the work. So I'll just make sure that you can see some of the resources cited here. And John, would you like me to go back to the beginning so people can see that slide with the...
I think Paula can put the code again in the chat, and we can take the slides down, and then now we've got a good solid 15-20 minutes for dialogue, which is fantastic. And so it was great, the little alarm sound there, because on a couple levels. One is like we're getting so used to being constantly alarmed. The other is that it's so sort of computerized and mechanical, and I'm turning down my volume to see is it around me here in my office? Is it in my head? And then you acknowledged it and oriented us. That was kind of cool. So let's go ahead and figure out a way to have some dialogue. I'll do my best to try to track this. I would invite people to put questions in the chat if you want. You can raise your hand. You can, if you're on a phone and it's not easy to do any of those things, just unmute and shout out for a moment. I would make a special invitation for a couple of categories of folks. I see we have a number of learners on the grand rounds. Would love to hear your thoughts and questions. Also, I see folks from other campuses other than the IOL, like St. Vincent's. Would love to make some space for you as well. So as you're and not excluding anybody, but just some special shout outs. So, and I just to comment, a couple of just initial reactions, Jennifer, from my point of view. In addition to being full of really helpful and useful information on an experiential level, your presentation was reassuring in at least two ways. One is that because many of us are so busy doing so many things, and when we interface with the wellness or well-being department or patient experience, it's a thin slice of what you do, and so that your presentation shows just how much work and depth and understanding goes into it, and again to just call out the psychological mental health way in which it's grounded is really reassuring. That it's about as close as you can get to trying to figure this stuff out. And the second thing is just that it's about people. At the end of the day, you're a person, you got your team, and that really comes across. Okay, so with that, let's see what we have. And I can't really read the room easily. I only see a few people on video. I'm going to look around. I see one comment in the chat, and this says the presentation, Sarah Young says, the presentation has felt attuned and validating to your target audience. Sarah, is there anything more you want to say about that or ask a question about it?
I'd love to add that I am one of the learners you're talking about. I'm an MSW intern currently, and I've loved hearing you talk about and name the trauma-informed culture that I think we're all striving for. I had a training recently about trauma-informed culture as well, and talking about how it really comes from the individual and the peer support. So it just felt incredibly validating to be experiencing these tough emotions in the workplace and hear that from an organizational perspective, we're valuing our staff's backgrounds and traumatic experiences as they bring them into the workplace. So just thank you. It was wonderful and validating.
Jennifer, do you want to actually, before you respond, Sarah, you remind me of another Sarah, Sarah Jones, I think, at the Hospital for Central Connecticut, inpatient social worker, who at the end of a presentation said she wished everyone a vulnerable day, which was the first time I'd heard that, which was pretty cool. Jennifer, do you have a response?
I just was going to say thank you for that feedback, and also that I was in a meeting yesterday. It was a Zoom meeting. It was actually I was with Scott Siniscali, and we were co-facilitating what could almost be described as a support group for some managers, and somebody cried. Somebody became emotional in the meeting, and they immediately apologized for it. And I'm thinking of it now. I don't remember exactly what I said in the moment, but her colleagues rushed to her and said, "It's okay. We have this. We're feeling this way too." What I should have said is, "Thank you for crying in the meeting. Please don't turn your video off. It's okay. We should all be crying in the meeting." So I think that speaks to what you're talking about, and is a lot of the work that we're doing.
Yeah, that's a great point. And you mentioned mindfulness. I think I've told you that I'm taking this online free mindfulness-based stress reduction course out of UMass for the first time in my life. And Tara Brock does a lot of the lectures. And I was listening to her this morning, and during her lecture, to an empty Zoom, room, she became tearful, talking about climate change, actually. And it was really, my experience of that was that she's really got great sort of skill and musculature for doing that in all her mindfulness work. Kevin Young, thanks for the brilliant presentation. How would you think about, oh, you have a question here, Kevin. Do you want to unmute and ask your question? Or maybe you're driving? So I can read it. How would you think about the culture change needed for opt-out support, and any thoughts of what you might target as programs or processes?
Oh, goodness. This is what I mean about people asking hard questions. This is a hard one because it bumps up again. There's this tension, right? There's this sense that, like, if we make people do something, we don't want to engage in something that I'm made to do, right? It has to. We've seen this in any sort of like crisis debriefing that sometimes happens after like an adverse event. Sometimes, people will call, the managers will call the EAP, for instance, and bring some EAP resources in to sit with people and process their feelings about what just happened. And if this is made mandatory, there is resistance to participating in it. But if it isn't made mandatory, then nobody comes. So there's a difficulty there. I think part of the culture work is in normalizing help seeking. And then some of the operational work is in something like, I know at Yale, they do opt-out behavioral health visits for all their residents. And that is helpful in the sense that, like, it's something that's already scheduled for you. Maybe not scheduled on your schedule, but there's almost an expectation that you do this thing. It's here for you. We have a resource. We've already paid for it. And if you don't want it, you have to call and say, "No, thank you. But we'd like you to do it because we think it's really important." So that might be a relatively easy way to start.
Fantastic. A couple comments on that. Julia said, just noticed that this isn't, this is opt-in, and there are over 100, actually there were like 180 at one point plus people here, which is interesting about Zoom, that we are, in some ways able to get better participation than in person. And then Mitch said, universal precautions as an organization assume that all of us are suffering from some level of trauma. That concept does help normalize help seeking. And to thank you for this. And okay, and before going to Dr. Mahendru, and who's using the trick of saying stack in the chat, which is another way to kind of raise your hand, and then we'll go to Dr. Cruz and Dr. Fox. I just want to again invite, and I see Dr. Berescu, somebody from St. Vincent's to join in at some point. Okay, Raveen.
Thanks, Jen. This was timely, brilliant, and good on many levels. I want to go back to something you mentioned, which has minimally to do with trauma-informed, but more to do with incentivizing and improving work satisfaction. So, you know, I think there is no substitute to actually having inclusive conversations with people when there is a major change to be done. Apropos, in my case, I can tell you that getting people to adopt Epic was a Herculean task, and the only way I could do it was with a group of people who had the patience to sit and listen to all kinds of angst. The question I have is, and I've also been proposing, so there is a system in NHS where a portion of the 40 hours are actually devoted to anything that the person wants to do, be it research, be it study, be it anything else. And that has improved work satisfaction dramatically, and it's been going on for about 20 years there now. How close are we as an organization to start adopting? You said a 15%, I'm saying a 10% option for indulging your faculties in things related and unrelated to work, but not work.
That's a tough, that I don't know the answer to that. I suspect those decisions would be made locally in our entities. And I think it's a little harder because we're not an academic medical center. And that's where I've seen more of that, I guess, standardization happen in terms of how people spend their time and what they're incentivized to do.
Excellent, thank you. And I know we're quickly running out of time. I want to quickly lift up Amy, your question about, can you speak to how HHC administrators are engaging in this? And I just quickly say that I am concerned about what I'm worried about is a declining comfort in showing vulnerability in leadership, and maybe we'll come back to that. But let's go to Dr. Cruz first.
Dr. Ferrand, I want to commend you for your ambitious taking on of probably one of the most salient issues facing our society in the past couple of years. And I'm not surprised. And I'm curious, you know, what you're seeing on the medical side. This relates to what Dr. Santipietra just said about this inherent tension of wanting to support the well-being of our healthcare providers because it's the right thing to do. They're not doing well, and it's all over the media. And with also this need to protect and serve the people in our society as they're getting ill under extraordinary circumstances. And if you're seeing, you know, how you're seeing that tension play out and what you're seeing in the leaders and how they're navigating this on the medical side.
Thank you for the challenging question. I think that the answer ties into John's comment, because I think what I'm seeing most is avoidance of the whole thing. Right. So like there is, you know, when we started to launch the well-being index and we started to ask people, please monitor your well-being and, you know, talk to your leader when you're not doing well. Well, that's exactly what started happening in a lot of places. And people would come to their leader and say, well, the well-being index says that I'm burned out and that I'm at risk for all kinds of problems. What do I do? And then the leader, a lot of times, doesn't know what to do. So I would say personally, I've gotten a lot of phone calls, and when I'm identified as somebody who might take these calls and do some coaching with you as a leader on how you, like what you might say in a situation like this, and how you don't necessarily have to fix the problem. The burden on the leader is that you have to hold a lot of things and be comfortable holding it without necessarily trying to fix everything, and that it's okay to show the people your vulnerability because you're human too. I've been able to give more people that message, and I think the more we can reinforce that, all of us, the more it will get through. But that is a very difficult issue.
And Marie kind of comments related to that it's inauthentic if we don't do it, and brings out that word authenticity, which I think is really crucial. Also, she said she's in the cancer center, and can we send her some of these materials? So let's make sure we figure out a way to get the materials out. Evan?
Yeah, thank you, Jennifer, as always, and really appreciate your grace in all your presentations, and also the language that is that takes some time to metabolize. And to that point, I hope that the organization, but also our department, will invite you back, because I think on a quarterly or a more regular basis, we need to hear this over and over again to nudge us towards and beyond the resistance that you spoke about. My question, which I realize is complicated, but what the hell? The unintended consequence of this is actually exposing the possibility that we're actually feeling worse than we are or admit to, and how that affects us professionally, and consequently then to the work we do. And the work we do also presents, right, so much beyond the level of stress, the narratives that sometimes are not digested, understood, and can be worked with. And so there's a compounding effect. And in addition to this, we're being asked, right, from a DEI perspective, as another initiative, right, to look in the mirror. And another resistance to doing that, because of all that exposes in what we know, and more importantly, what we don't about ourselves. And so it seems to me that your job and the messages that you continually give us every month are so imperative. What could we do in sort of in small ways on a daily basis, in ways that we already are organized, to continue to refine what we're naming, and how naming these processes and events or circumstances can then assist us, given the tools that you're giving us to manage them better? If I hope I was clear in my question, because it's a lot.
I'm going to try and answer this. One of the reasons that I wanted to present this topic to this audience is because you're the experts in this, and I think you can inform the rest of the organization around the very questions you're asking, Evan. And you know what stands out in my mind is that recently I was talking to an ER doc, and I was like, "Oh, I'm gonna talk about trauma-informed care in the behavioral health network," and she said, "Well, in the ED space, we think of trauma in a much different way than you think of trauma." And I hadn't really ever thought of that. I always thought that, well, trauma is emotional trauma, right? But when, in interfacing with people who don't practice behavioral health, they think of trauma in a much different way. So really my ask of you all is this the way to be talking about trauma? And is this something we can get on board with as an organization? And is this something that we have to be scared about, right? We've had the experience of having to be sort of careful about the way we message things. And I appreciate that on the one hand, but it makes my job a lot more difficult. And it means that we spend a lot of time thinking very carefully about the language we use and the impact it's going to have on people. I think that's great, but it just kind of it gives me one more thing to think about and be almost careful about, that is both a gift and a challenge. I don't think I've answered your question very well, but those are the things that came to my mind.
Well, I think it was both a great question and a great way to start answering it. And we're not going to get to them all. Just note that Dr. Hamill raises what would take a while to get to. And I know the organizations would have tried to balance the, we want to take care of wellness on the one hand. We also want to eliminate things that we are doing that contribute to unwellness and unnecessary tasks and that sort of thing. How do you balance that? I will also note Dr. Hamill, who graduated from the residency here, is in private practice. I think he's already full, but he's got a great website. You can Google him. I don't know if there's a conflict in my saying that, but who cares? So let's wrap up. One last thought just about this, and maybe it's in some of the questions, but actually Dr. Sukhera talked about it in relation to DEI work, is there's an importance in doing. There's also an important task in being, right? It's not just about doing, it's about being. And I think, one of the things that's really fun in listening to you and dialoguing with you, Jennifer, is that you really, I think bring both sides, both of those things in full measure. And so hopefully we'll be able to continue this dialogue. Lots of positive feedback in the comments. And with that, I think, Paula, we can stop the recording. Thank you, Jennifer.
Thank you.
Thanks, everybody.